this up by having a conversation about GME policies and legislation that are currently either in their process or have just finished through some of the state budget work that happened back in June, just to give you a sense of where we're currently at as it relates to GME opportunities and sort of what's coming up. What we'll talk about today are a number of different things that touch on policy, but a little bit on programming too. So as it relates to policy, we'll touch upon the SAC GME dollars and the current legislative efforts that are going on at the federal level to continue and reauthorize funding there. Talk a little bit just really quickly about the Song Brown and the Cal Metaphors programs that we discussed yesterday. In addition to a state plan amendment that we referenced yesterday that now allows health centers that are accredited and are either federally or state sponsored to get PPS reimbursement for services provided by physician residents. And then a little bit about some of the work we've been doing that ties into this training, along with the residency framework that we have in place here at CPCA for our members. All right, so going a little bit into the policy first before we get into programming. As many of you know, HRSA, the Health Resources and Services Administration, has what they call the Teaching Health Center Graduate Medical Education Program. Really, this program came out of the ACA, really as a way to build the workforce in community-based settings. Many of them across the country are located in community health centers. Here in California, we have 8 teaching health center grants across 6 different sites. The 6 that you see up here are those that are currently funded through HRSA THC GME dollars. And what's really neat about that is that you see them represented really across the state. In this map here, they are the yellow dots. So Shasta Community Health Center, the Valley Consortium for Medical Education, Valley Health Team, Clinica Sierra Vista, SAC Health System, and then Family Health Centers of San Diego. Currently are 6 different sites. The most of them are family medicine based, but as we referenced yesterday with Dr. Shannon's presentation, they do have a psychiatry and a pediatrics teaching health center program as well. In the event that you are not aware, the teaching health center application through HRSA is currently open. It really is as a result of some funds that were available through the THC reauthorization that happened 2 years ago. It closes on August 30th and currently has funding available for all of the existing teaching health center slots, but also funding for up to 5 new programs across the country. So I point that out also because I know we have 3 newly accredited programs that received their accreditation within the last year. One in the San Ysidro Health. I know we've been referencing you all a lot. There's another one in Borrego Health as well in the Hemet area. And then Lifelong Medical Care with Deborah. And then we expect to have, of course, Ultimate accredited in October. And so that's sort of where we're at currently in terms of today. But I know a lot of folks have been really anxious about, recognizing that the teaching health center funding runs out in this September, so in just a couple months. We need to be doing a lot more to make sure that this program is sustained for the next several years. And so for the last several months, there's been legislative efforts by many different federal representatives to really make sure that this funding continues. Right now, where our attention is focused is on 2 different bills, one on the House side, one on the Senate side. And as you can see here, the House adopted legislation that provides level funding for 4 years versus the Senate adopted legislation that provides level funding as well, but for 5 years. The thing to keep in mind with this legislation is that it's not just teaching health center focused, sort of a package bill that includes teaching health center funding, National Health Service Corps funding, and a bunch of other things. So, given the complexity of these two bills, and the fact that they have some controversial elements in them, they are going through somewhat of a negotiations process on both sides. So at the end of the day, if through negotiations they look different, they will continue to go through that process of being evaluated on both sides to then look at what gets pushed through in the end. The other thing that I want to point out as it relates to this federal process is that both the House and the Senate are on recess right now until September 9th. And what we would just encourage you to do generally beyond this time where we're looking at legislation for reauthorization is to really engage with your members of Congress to educate them about whether you have an existing program or an existing partnership. But if you don't, also talk to them about how interested you are to develop programs like this, because that's the level of information that they're also constantly asking for. Okay, we know where there's been programs, but where is their interest? And that helps them in their negotiations process to sort of say, oh, well, in my region, 2 programs they're looking to set up. It sort of brings that level of priority up for them personally. But then, when we look at a bigger picture, we can say, across the country, we're looking that there are 10 organizations that are looking to develop new programs, and that's why we need this much more funding. So really, what I'm trying to say here is share your story, share what you're working on, and share the impact that this kind of training provides not only for your organization, but also for your patients. So now digging in a little bit into the state, you heard us reference this yesterday, but funding for both the CalMed Force program and the Song Brown program, Governor Newsom committed ongoing state investments in this space because especially the Song Brown program relies on general fund allocations. It is still somewhat of an annual fight to make sure that that continues to be in there. Just because he committed to ongoing funding doesn't mean it's in there permanently. It is still subject to, legislative interest as a whole. So know that CPCA will continue to advocate for these dollars as the time goes on, but it's definitely a huge change in what we've seen in our state over many years. This is the first time, I believe, that we have this much funding for GME. So I know we went over this a little yesterday, but there's $31 million under Song Brown for this application cycle that's currently in effect. And come September, you'll also see the application roll through for $38 million under CalMed Force. And these are the buckets of funding available under each of the 2 programs. As you can see, CalMed Force is divided up by specialty. Song Brown is more so, where are you in that process? Are you existing? Are you trying to expand? Are you a brand new program? Are you just, sustaining your existing slots? So that's that. And in terms of how this has had an effect on community health centers, before Song Brown received the $33 million allocation over the course of 3 years, i.e. the $100 million push that we here at CPCA did alongside CMA, CHA, the Academy of Family Physicians, and others. Back in 2016, before all of that even went to effect, you saw that health centers, residency programs received about $1 million from Song Brown. But when we started to see that 31 million allocation to Song Brown each year, specifically for the programs, that number jumped incredibly higher. So We saw in 2017 over $6 million allocated to our health center residency programs. In 2018, close to $10 million. So this is a pretty big, just success of what collective advocacy can be doing in this space. And as it relates to CalMed Force, as we shared yesterday, all of the health center applicants that applied for CalMed Force in its first cycle received funding. And this is just a quick reminder of the funding application dates. Song Brown applications did close, and so the funding meeting will be happening next month, which we encourage all of our applicants to attend, because we do end up having very robust discussions there, and sometimes it can change the outcomes of the meeting. And as it relates to CalMed Force, sort of reiterating, it opens soon, and then it will be closing in October. The state plan amendment. So some of you, I know, are curious about some of this. So last year, CPCA worked very closely with the Department of Healthcare Services to move forward a state plan amendment that would essentially authorize PPS reimbursement for teaching health center resident physicians at FQHCs and RHCs. The core eligibility components are that the health center must have an accredited program by ACGME. It must be federally or state sponsored, meaning you either have HRSA funding, that's the federal portion of it, or state sponsored means you either have Song Brown or CalMed Force program funding. And your medical residents must have at least 6 months of training to get these reimbursements for. So in all reality, I will be honest with you, this really targets those programs that have been teaching health centers and that became newly accredited as of a couple months ago, but that also have either HRSA or state funding. So the pool of health centers that can really benefit from this is smaller than what we would like to see. We did, in our conversations with the Department of Healthcare Services, advocate for the continuity clinics and the rotation sites to be included, but unfortunately that was not adopted in the SPA that was approved by CMS back in September of last year, but it was retroactive to April of 2018. But
Natalie, do you have an understanding of why they objected to the continuity? Is it just money?
That was a large part of it, yes, to be very honest with you.
So I'm confused on the site. Are you saying that, are you making the point of that it's a triggering event to recalculate your PPS, or is this something else that you're saying?
Yeah, so in order to, get these reimbursements, it does require a change in scope because they're going to be considering the additional costs that you have taken on as a result of training.
But this isn't talking about like the actual residents billing on a patient, is it? That's not what the slide's about.
I'm going to get to it here,
Okay.
but yes, let me finish going through and then we'll get there. Because you'll see in this slide, I'm going to begin to layer things on top. So this slide touches a little bit about what we discussed yesterday with Kiki. There are changes that are going into effect on January 1st, 2020, such that all residents, whether they were trained in the U.S. or internationally, will have to complete 36 months of postgraduate training to receive their unrestricted license. This is different from the current process where right now, if you train domestically, you get your unrestricted license after your first year. International students, I believe it's after 24 months. So it's different for either group right now. But moving forward to January, everyone, 36 months. And before they get their 36 months of training done, what will happen is those residents will be required to have a postgraduate training license in order to practice and train within the residency program.
Do you know what's the background on this?
Yeah, so a couple things. This was approved actually as part of a really big bill that was part of the sunset bill for the medical board. So it was a bill that was essentially saying, yes, the medical board can continue to exist. They packed a bunch of stuff in it, and just a few sentences in this was this change. We talked to the medical board about this, sort of what prompted this, what were they looking to achieve. A lot of it comes down to patient safety, which that's their big role. So right now, recognizing folks are submitting applications to be licensed once they've really done 1 year of training, right? Or in the international case, 24 months. So up until that time, they don't know that you're in California training and seeing patients until they get that application from you. So one of the reasons was, I want to know from the beginning, when a resident starts their training, who you are, where you're practicing, those kinds of details. So they have a more full inventory of all the trainees in California. Another side of it was also recognizing the differences between domestic and international, wanting to line those timelines up. I'll also say that this is a model that has been adopted by other states. So that was another effort to align processes with other states as well. So that's some of what we've been told through our conversations with the medical board. And sort of how this begins to layer on with some of what we discussed as it relates to the spa. So billing is going to look a little bit different for those health centers that have accredited programs versus those that are continuity clinic sites or rotation sites. For the accredited programs that have HRSA or state funding, for residents while they're in 0 to 6 months, the billing will need to occur under the teaching physician, and the teaching physician must be physically present in the room for the visit. Right, so it's that scenario where right now they're unlicensed. Similar thing.
They have to be in the room for the whole visit, or go in and see the patient at some point during the visit.
Let me get back to you in terms of how long they have to be there, but I know for sure the provider needs to be in the room for less than 6 months.
Yeah, go back and repeat whatever is important in the history of business.
Okay.
With the spa, that is now in effect, right, what we just talked about over here, all right, it says here medical residents must have at least 6 months of experience in a GME program. So once they've hit that 6-month mark, sort of that 7 months to licensure, which starting in January 1st will be 36 months of training when they get licensed. The billing will still need to occur under the teaching physician, but the change in this sort of phase is that the teaching physician will not need to be physically present in the room, but must be readily available. Okay, so that's what is reflected in this state plan amendment. So that's, like I said, for the accredited programs that have HRSA or state funding. For all of the health centers that are continuity clinics or rotation sites, this is where things are not clear quite yet. We've had conversations with the Department of Healthcare Services, the Department of Managed Healthcare, the medical board, and we have not gotten clear guidance on how those folks will be billing. Because like I said, continuity clinics and rotation sites don't qualify for that SPA, so therefore their billing will be a little bit different. And because there is still somewhat of a gray space, we are working with the lawyer to understand some of this, but are also convening a work group in about 2 weeks with some members to try to figure out what our next steps can be. Any questions before I move on?
Is SPA the same thing as the primary care exception, or are we talking about two different things?
They're two different things. So the SPA was this one, the state plan amendment, but I'll tell you that this state plan amendment was modeled off of the Medicare exemption rule. That's what the department was trying to do with this.
So primary care exemption is a Medicare thing.
Right, and it's hospital based.
And this is California state.
Yeah, state plan amendment too. So that's all of the policy changes that we've seen in the GME space most recently. Of course, there's a lot of interest to enhance funding that is already in place. And, you know, there's obviously concerns that we have about some of this stuff here as it relates to billing. So that work will continue. You may also know that the California Future Health Workforce Commission, it was a commission that came together in the last year and a half at this point to create a master plan for addressing California's workforce shortages in primary care and behavioral health and in the geriatric workforce. Within their master plan, they did have a whole recommendation on enhancing graduate medical education. The recommendation itself breaks up into 5 different pieces about, you know, enhancing Sam Brown and CalMed force funding and developing a Medi-Cal, GME strategy, among a number of different things. So hence why I said earlier there's a lot of appetite to continue developing in this space within our state. But as it relates to programming, some of the things that we've been doing here at CPCA is developing trainings exactly like the one we've had here over the last 2 days, but also developing a series of toolkits to really assist call centers in developing new programs or new training sites, but also strengthening those existing programs. And so, like I said, the training that we've had over the last 2 days is a part of this larger program that we have been able to do with support from Kaiser Permanente Community Health, both northern and southern regions, but also, of course, due to the fabulous collaboration that we've had with WIPFLi and Kiki in developing all of this work. So, you know, while we have had a lot of content that we've shared with you all over the last 2 days, as you know, these trainings are being recorded. They will be put into webcast form on our website, so you can access them at a later time. If you said, hey, I remember she said something, but I need to go back and check that out, it'll be on there. We have also on here a GME library, so, you know, a bunch of links to different resources that we recommend everyone to check out. The GME Learning tab is really where we've been listing all of our training opportunities like this one. We have a GME funding page, lists all the GME funding opportunities. And we will be, over the next several months, developing a series of other toolkits. We've had one, this one here, the Pathways to Residency, that we developed a couple months ago. We'll be releasing one soon on GME funding. So it'll include some of the stuff that we just talked about as it relates to the billing, once we can figure that out. We'll be developing another one as it relates to accreditation, sort of a step-by-step how you do that. And then we'll be looking at developing a self-assessment tool as well. Some more to come. But in the meantime, I do want to invite you all to participate if you aren't in this network already. CPCA brought together what we're calling our Residency peer network for about 2-3 years now. We've had this group. We meet bi-monthly via conference calls to discuss all of the legislation that's moving forward. So what I mentioned at the very beginning, we talk about, especially as it progresses, hey, health centers, this is the update. This is what we recommend you do to advocate for this funding. Things like that. We'll go over federal and state legislation, but also have guest speakers come in and talk to you all and try to promote as much peer-to-peer learning as possible amongst the different programs. So like I said, that's available to all CPCA members, which really many of you are a part of our CPCA membership. So if you're interested in joining, just let me know and we can sign you up on our distribution list. And that's all I have for you all today. Like I said, we did an overview of policy and programming, but do you all have any questions as it relates to what I just presented? No? Y'all are ready to go home? It's okay, I totally get it. It's been a long 2 days. So with that, I think unless any of you have any questions, comments, or concerns, we'll wrap up our 2-day GME training. And thank you all for participating. Really, I know this is the beginning of a larger conversation. So as you go through and implement some of what you've learned over the last 2 days, please keep us up to date. Let us know if you have any questions or concerns, because really CPCA is here to help you in that space, both policy and programming. So thank you all for coming.